I'll introduce our first speaker, Dr. Alex Vakili. We'll go ahead and get started with FMD basics. Alex is our current vascular medicine fellow here at Emory. He's also a cardiology fellow as well. He'll be graduating this year, and he's done such a good job that we've hired him to retain him to work at Emory Midtown next year, and will be part of our vascular medicine team. So you may be seeing him in clinic in the future as well. And appreciate you being here.
Thank you so much. Thanks for having me.
I know he's had a rough week, so thank him when you see him later on. It's been a busy week for Alex.
Yeah.
Okay.
Good morning again. My name is Alexander Vakili. Thank you, Dr. Wells, for the introduction, and thank you guys for all traveling so far and coming to hear our talks. I'm going to start with some fibromuscular dysplasia basics. As you see in your schedules, there'll be a lot of different subspecialists that'll be here that can help answer kind of some more focused questions in different kind of fields, but this is to kind of just set our basics for the morning. I unfortunately don't have any financial disclosures yet, but we'll see how that develops in the future. So just outline what we're going to do. We're going to talk about what is fibromuscular dysplasia. We're going to review some common medical terminology that will probably be used throughout the rest of the day. Do a little bit of historical background, what causes it, when do we suspect fibromuscular dysplasia, and how do we diagnose and classify it. And then Dr. Wells is going to follow up with kind of how do we focus on management and treatment for that. So fibromuscular dysplasia, essentially abnormal growth or development of cells, is this non-atherosclerotic, which we'll get into, non-inflammatory vascular disease that may result in arterial stenosis, occlusion, aneurysm, or dissection. We don't have a definitive cause that we've identified yet. And the most common sites that we see that are involved are the renal, so the kidneys, and the extracranial carotid, so the blood vessels that go to the neck. Those are about 65% of the cases. Most commonly, we diagnose this in women, and our average age of diagnosis is around the age of 52. Presenting symptoms tend to be a little bit before that. There's a delay to patients actually getting diagnosed with fibromuscular dysplasia. Part of that is just because of lack of great understanding of the disease. You know, I think that this is something that, as you guys all know, we may have to sometimes funnel towards our academic centers to really fully appreciate this. And then most commonly, patients will have hypertension, so elevated blood pressure, headache, and pulsatile tinnitus, which is essentially a kind of whooshing or swooshing sound that people will hear in their ears. So, common terminology. So on the left, you'll see a normal artery. So the artery, just basics, are the blood vessels that take blood from the heart and pump it out to the rest of our organs throughout the rest of the body. That's what takes the oxygen out, and the veins bring it back in. When we look at what's called stenosis, you can see that here we'll talk about two specific types. There's atherosclerosis, which is the buildup of plaque or cholesterol that you'll see here. This is what we call traditional, good old Southern food, fried chicken, smoking, diabetes. This is where we commonly see this. And then we have what's called hyperplasia, which if you see, let's see if this mouse will pull it up. If you guys can see my mouse, yeah. So you'll see that this part of the artery wall right here, there's multiple layers. There's an intima, an inside, a media, middle, and an adventitia, the outer layer. And you'll see that there can be growth of different layers of that vessel, which can cause in itself stenosis and this common term that we use, the string of beads. Tortuosity, so what is that? Tortuosity, blood vessels typically flow like our pipes, just in like below our sinks, but you'll also see that there's these tortuous vessels that we'll notice. There's a term called aneurysm, which is where there's an outpouching or kind of dilation of the blood vessels themselves. And so you'll see saccular aneurysm versus fusiform. And then dissection, which we'll have a whole topic about that as well, which is where there's actually a tear in one of those layers of the blood vessel, and then blood will flow down into that area. Sometimes you can form clot, and that can itself create a type of stenosis. When you're seeing us in the office, we're doing our physical examination, we're listening with our stethoscopes, and part of this is what are we listening for? And so with fibromuscular dysplasia, as well as with these stenoses, or narrowing of the blood vessels, there's an abnormal sound that we'll hear with our stethoscope. So this should be a normal sound. Let's see if we can get it to play. This is our normal heart sound. Dun, 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 dun. And you'll see that those are pretty crisp sounds that we're appreciating. And then here, this is the sound of a bruit, which is that sound of the blood flow going through that stenotic region. So that sound in itself, we typically call it, or kind of one of the examples I've heard Dr. Wells use is kind of like the whitewater rafting. So if you're going down a straight river, you'll see that the water just flows nice and easily. But if you're going down kind of a whitewater river, you'll see that all those turns and crevices will create this kind of whooshing sensation in that sound. And that can be what we're hearing in those cranial arteries that we're appreciating, the carotids and the vertebrals. What we'll do is that we'll listen to the areas of the neck. We want to try to make sure that we're listening up towards the jaw. Traditionally in cardiology and other specialties, people listen a little bit lower. That's where the atherosclerotic development is, typically at the branch of those vessels. We'll also listen at the abdomen, which can appreciate some of those renal arteries, the kidney arteries that we appreciate, and some of the other arteries that feed the intestines and the other organs. And then also the upper legs or the groins, where our femoral arteries are, and our iliac arteries, where we can also have some involvement. So for some historical background, the first case of fibromuscular dysplasia that we have in our literature was back in 1938 by Ledbetter and Birkeland, where they diagnosed a 5.5-year-old boy with severe hypertension, very elevated blood pressure, and a renal artery that was partially occluded by some intra-arterial mass, so some mass that was inside of there. They actually cured his hypertension by doing a unilateral nephrectomy, which is where they remove the kidney. And they looked at it under the microscope, and they identified that there was this abnormality there. Slowly over time, you can see that there's big gaps in the years here. But the term fibromuscular hyperplasia was introduced after a few cases were identified by McCormick. And then there were also identifications by Polobinskas and Ripley that looked at cerebrovascular. And so cerebrovascular, we're talking about the head and the blood vessels involving that area as a cause of the non-atherosclerotic internal carotid artery stenosis and stroke. We later developed some pathologic, which is where we look at tissue under a microscope. We looked at for some criteria there. And then using the FMD registry, we're able to kind of put out some publications starting around 2012. And we'll get some more topics about that. So how rare is FMD? You know, initially we were taught this is a very rare condition. This is something that typically occurs in young women. It does occur most commonly in women with a ratio of 9:1. We do see that the men that are affected do tend to have severe clinical manifestations of this involving dissections or aneurysms. Using different kind of research studies that are put out there for various reasons, as well as there's autopsy data and there's different types of what we call angiographic, which is where we look at the blood vessels themselves. We can see that the prevalence is about 3 to 6% for the renal artery, FMD, as well as carotid artery, just under 3% for that. This is something that's growing. We're going to, I think, identify this more and more as we get more funding and more research opportunities for that. One other thing to kind of bring attention to this is that people aren't typically always looking for this fibromuscular dysplasia. Sometimes we're traditionally looking for that atherosclerotic. They're looking for the narrowing of the blood vessels that go to the kidneys. There are actually studies out there that they looked at, does it help serve somebody that has cholesterol buildup in those arteries to open those up with stenting? And we incidentally found when we went back through some of that data that, you know, some of these patients do have fibromuscular dysplasia, and we need to appreciate that a little bit more. What causes it? Like I said at the beginning, we're still unknown. Familial cases are present in about 7 to 11%. There's no great kind of family testing algorithm that we've created or guideline that says if one family member has it, all other family members need to be screened. We do see that patients that smoke have more severe disease and higher rates of aneurysm and vascular events, what we call strokes, heart attacks. This is just in general smoking, bad thing. Let's walk away with that for sure. And then in terms of this kind of female predominance, there was also some studies that were out there that looked at, you know, does the use of oral contraceptive pills kind of push this? Does the use of like how many pregnancies they've had? Is there some kind of pattern that we can fully identify there? And we haven't been able to identify that yet. And then there's other kind of what we call monogenic or these single gene abnormalities, connective tissue disorders like Loeys-Dietz, Marfan syndromes that we've tried to look and see, are there any overlaps in any of those genes? And right now there's still low levels of overlap that we're seeing there. One of the promising kind of allele variants, so kind of mutations in this gene that we're seeing, is called factor 1, and there's more research being done about this, but it can be associated with cervical artery dissection, hypertension, migraine headache, and FMD. So when do we suspect FMD? So this is for primary care providers, this is for your general cardiologist, this is for anybody that's out there, should really be thinking about this. And for our patients ourselves, like sometimes it's up to you guys to say, you know, I think something else is going on. I need somebody else to take a deep look at this. So patients that have high blood pressure, okay, and in the population that we don't typically see it in, so in the younger population, so under the age of 35, somebody that typically had normal blood pressure and it suddenly changed. You hear those carotid bruits or those bruits on our examination that we do. Somebody says, I hear something abnormal, we should do some more testing for that. Somebody that has severe persistent headaches or pulsatile tinnitus that we can't explain from any other way, or any type of dissection or aneurysm, since there is a prevalence of this in fibromuscular dysplasia, we should look in other regions to see if there's any involvement. Subarachnoid hemorrhage, I'm sure we'll talk about in our neurology talk later today, and then renal infarction, so kind of like a heart attack of the kidney. Using the FMD registry, these are some of the statistics that were put out looking at what the presenting symptoms were, and you can see extremely highly that hypertension, so high blood pressure, was up there, 63%. Headache, almost half of people had headache that was there, and at least half of those were related to migraine. Pulsatile tinnitus, so that whooshing sensation that you're hearing in the ears, and dizziness as well. A lot of these are non-specific symptoms that people will typically get blown over, but you know, once you put everything together and with the imaging findings, we can help make that diagnosis. And how do we formally diagnose this? There's no blood test, there's no biopsy that we're doing. We're no longer doing these like autopsies or pathology specimens or anything like that looking under a microscope, but we're using a lot of different types of non-invasive imaging, such as ultrasound. We're using MRA, so MRI technology, as well as CT or CAT scan technology. And then the gold standard, so what we consider our best test, is using a catheter-based invasive angiography. That's where they go either through one of the arteries in the wrist, or you go through the leg, and you essentially set up an IV with a plastic tube that goes and injects dye, and using an X-ray type machine, kind of sits over top of you. We take different photos and we can look at the blood vessels in different types of planes, and we'll show some pictures of that. This is not to get into too much detail, but just to kind of show you a little historical, like how we classify it. And traditionally histological, so looking at those pieces of tissue underneath the microscope. Medial fibroplasia, that middle segment growing and getting larger, is the most common. Intimal, kind of that inner layer, and then adventitial, the outer layer, is less common. But we've had to transition over to what's called the angiographic classifications, and these angiographic classifications are because more and more commonly people are just, like we said, we're not doing a lot of these invasive things. We're looking at ultrasound, we're looking at MRI, we're looking at CAT scan, and we can help determine multifocal versus focal. Multifocal is what we typically call the beaded, beads on a string appearance. And then focal is kind of one more finite area that I'll show some images of. Our focal patients typically tend to be more with high blood pressure involving the kidney, and then also they tend to respond a little bit better to some of our therapies. And they tend to be a little bit younger. So multifocal FMD. So what we're seeing here, I'll kind of show you guys. Slide A, this is the beads on a string. This is the carotid artery that we're seeing here on one of our angiograms, and you can see that this is regular down here, and then it becomes very irregular here. B, this is our renal, so this is the kidney segment right here, looks like a little kidney bean, and the artery that feeds out, there's a little catheter here injecting some dye, and you can see how irregular this region is. And this is that multifocal consistent with medial fibroplasia. And this is the histologic evaluation of it. So you can see that there's this kind of rough ridges, there's all this extra growth. This is all abnormal. And then focal fibromuscular dysplasia, you can see that there's these more finite regions right here, kind of small areas. And this can sometimes be thought to be related to other things like the atherosclerosis. but you can see that's coming up a little bit beyond the branch vessels. And then also here in the renal artery. And then this is that intimal hyperplasia, so the inside of the artery that's getting bigger and bigger. So renal FMD, what are the most common manifestations is high blood pressure. So patients will come in for some reason of high blood pressure. They're on multiple medicines and we're not sure exactly what's going on there. We will hear bruits in some of our patients. And if there is a dissection, which we looked at earlier, that tear of that blood vessel, patients can have abdominal pain in that region. Some of the good news, and we're still looking at this, but chronic kidney disease, end-stage renal disease, these are uncommon kind of effects of FMD at this point. But even despite if you have good controlled blood pressure, you can still have headaches with this, even if there's not involvement of the blood vessels that go up to the head. This is cerebrovascular, so carotid arteries, vertebral arteries that run down the back. Most commonly, people will have headaches and they'll have that pulsatile tinnitus. Cervical bruits can be the initial presenting sign in about 20% of patients. People will get referred for that. And then you'll have spontaneous carotid dissections. And so we'll kind of look at some of these photos together, but you'll see here, there's dissection flap here, and there's some clot there that kind of stops the contrast flow from going up. And then here you'll see this big kind of tortuous blood vessel with some irregularity there. That's the carotid artery as well. And so when somebody comes in with the spontaneous carotid dissection, 15 to 20% of those are due to FMD. And that may be the presenting symptom in some of our patients. Most commonly, we'll see, like I said, the headaches. You'll have TIA, transient ischemic attacks or strokes. You may get diagnosed with that. And the recurrence rate is relatively uncommon. These are some more kind of photos just kind of thrown up on the screen to show you what we're looking at in our vascular labs. And we're looking at different types of ultrasound imaging that show beaded kind of appearance of the blood vessels here. You can see that there's some irregular flow that you're noticing here. There's that tortuosity. So the S curve is something that Dr. Wells or one of us may kind of reference that we see on some of our scans. It doesn't mean that you have FMD. It doesn't mean you don't, but it is something that we see quite a bit. And then this is a picture of how fast the blood is flowing past that. This is some of our CAT scan results. So you can see here, we have to reconstruct it in different images and different planes. And right here, you'll see that irregularity as it kind of courses its way back up. There's going to be 2 full talks on coronary involvement in SCAD. So I'm going to kind of skip over that for now. And then aneurysm. So why is this relevant and why is it important to identify FMD? So 20% of our US registrants have at least one aortic or arterial aneurysm. You can see some of the statistics here. And less than 50% will have aneurysm or dissection. And these are some of the complications that we think about and that we worry about and we would like to identify for our patients, because fibromuscular dysplasia in itself, when we do our initial screening test, it's very rare. It's not typically seen as a progressive disease that you'll see some beaded appearance of one blood vessel area, and then a few years down the line, you'll notice a full, like another type of blood vessel area that's involved. But we can see that those involved areas can develop aneurysm or dissection, and that requires different types of treatment and different types of therapy. So we will recommend that one time we at least have our patients get scanned from kind of head to pelvis to look at all those blood vessel regions to make sure that there's no involvement. Now, in vascular medicine, there's a lot of other kind of vascular issues. We've talked a little bit about like some of these other genetic issues like Loeys-Dietz, vascular Ehlers-Danlos. There's other types of vasculitis, atherosclerosis, cocaine. There's so many different kind of differentials out there, and you may get diagnosed with fibromuscular dysplasia. Just looking at this one picture right here, we can see there's some of this beading. It's a little more subtle, but you do see that this is irregular in comparison to the kind of earlier part of this blood vessel right here. But it's important to diagnose like specifically. And this picture on the right is not fibromuscular dysplasia. This is actually what we call iatrogenic, or this is related to us, where we put a catheter in and we cause what's called spasm in that area. We'll get some what are called standing waves. And so we can essentially kind of rule that out with that. So a lot of times you'll have to bring your imaging in, we'll have to review these things, and we can help to try to like parse this out, and may take some expert radiology review as well as talking with you guys and talking with our vascular medicine specialists to really formally diagnose this. I know later in the day, we'll talk a little bit about the registries. This is the FMD Society of America. One of the goals is to identify patient characteristics with FMD and then try to help identify, like, using different types of imaging, treatment modalities, where we can go. As of July of 2023, I believe there are over 4,000 patients that have participated in this. So congratulations to those patients. And these are some of the centers that we see that are involved in that all across the country. And to date, almost 40 different manuscripts, abstracts, posters have been published and presented with this data. And so this is helping just grow the field of FMD and SCAD and helping us understand this a lot better. These are some of the physicians that are involved with the care here at Emory. If you go through our fibromuscular dysplasia website, you can kind of find referrals and identify different people that'll be involved there. Some of our speakers will be on here as well. And that's it. I just wanted to leave you guys with a little bit of an introduction and here for some questions. And thank you guys for coming.